qualified responses broken down by city, and the third are all responses that we got. So that includes all 18,472. What we want to leave you with are the overall response. 45% of respondents support staying with the public health order. 55% of respondents support opting out of the public health order. Of those 55% that want to opt out, 96% of them support a full opt-out. 1% support an opt-out based on geographic locations, such as the eastern side of the county, and 3% were listed as other. Most of the responses, when you look through the report, are citing age as their reason for that. So feeling that kids are too young, the age was too young to have kids in masks. Just so you have an idea of where the responses were coming from, 40% came from Aurora, 29% from Centennial, 13% from Littleton, 6% from Englewood, and 5% from unincorporated. The rest were all about 1% in terms of the rest of the cities and towns that we serve. I want to go back very quickly, in case you had a question, of those 12,000 or so responses that we disqualified. That was on purpose. If we had a response with an IP address that was outside of Colorado, we went ahead and took those out. And we also took out any IP address that submitted more than 2 responses, figuring there's probably 2 adults in a home that could give their opinions. So we took out any more than those. Just so you have an idea of the kind of response rates we were getting, one IP address submitted nearly 6,800 responses, and another one submitted about 2,300. We did see a lot of social media about this form. A lot of people wondering if this was the only criteria you were going to be using. It is not, as you talked about. You're going to hear some other presentations today. So again, what this feedback was designed to do was give you kind of a point in time snapshot of the feedback we were receiving electronically through the Commissioner's office. And want to make sure that you also know that in those reports that we gave you includes all 18,000 responses. So there are open-ended responses that we asked for, and you can read through those. You've already been pretty familiar with a lot of the responses that we've gotten to date because of it's a lot of the same that we've received over time during the pandemic. But that's the high-level overview. I'm curious, it looks like Commissioner Sharp has a question.
Thank you, and thanks, Chris. One of my questions was, we've gotten a lot of emails, and I want to say, I think you said about 160 emails that you included in the survey, but I'm thinking we got a whole lot more than 160. Some of them were to commissioners in general, which I think were included in the survey, and some were to us individually. Mm-hmm. And I know I tried to forward as many, we've gotten a whole bunch this morning, but I tried to forward as many as I could that looked like it came to me as an individual. So were those included as best as you could?
No, those responses, the responses that came to individual commissioners, we did not include because they were coming to each of you. So the ones that are included here are the ones that came to our Ask Arapahoe County email address. That's the standard one when you get on the website and want to ask a question. So we did aggregate those. If you'd like, we can take some of the ones that you all received and add them to this as an addendum to the report. That's something that would be useful for you.
Yeah, and so the ones that came to commissioners that went to all of us, those are not included?
I'm sorry, those are included. Yeah, any of
those are included, yeah. But just the ones that came, that look like they came to us individually are not included, correct?
Correct, yes, you are correct.
Okay, all right. I think I'd like to see how many that might be, but that's going to maybe be kind of a daunting task here to see how many. And it's hard to tell whether they came just to me individually or went to each one of the commissioners individually. But let's go ahead and keep going. But I think that information, I think, is important to just to recognize all the people that did take the time to email.
Great, and we did respond to the people that did email the commissioner's email address, And we gave some, I believe each of you have been doing some of that on your own personal ones as well.
Yeah, I know I tried to get to as many as I could, and I'm sure I've missed a lot, but
there were a lot, and I'm getting a note that we did get about 300 to the commissioner's email address. So that's included, and we will make sure that if you want some of the other ones added, we can try to tally them as best we can.
All right, thank you very much.
Mm-hmm.
Other questions for Chris? Or Chris, do you have any other information you want to share with us?
All we wanted to give you the high level where the information came from, what the sentiment was. Again, we have given you all of the responses and in 3 different reports, so all of the reports are there. Looks like Commissioner Holman has a question.
Thank you, Chris. From the addendum report that you gave, it showed about a 45% supportive of the Tri-County health position on masking, and 50 or 55% not supporting.
Correct. 45% of respondents support staying with the order, and 55% support opting out.
Okay, great. Thank you.
Mm-hmm.
Chris, this is Nancy J. Was there a way for you, I know you were tracking ISPs and so on. I got several emails telling me about, oh, this radio station is publicizing it, and these other social media, I don't know what you call them, venues, were publicizing this. Do you have any sense of whether or not there were organized campaigns on either side of this issue that were going on?
We were watching some of that, particularly through Facebook and Twitter. There were a lot of individuals who were forwarding the information to their followers saying, please fill out this survey. So again, that's why we're not calling this a statistically valid survey. There was one tweet that mentioned, you know, make sure you say you're a resident of Arapahoe County. So we do know that there is a inherent bias of some sort within these results, but wanted to give you some form of way of aggregating all of that information, so it gives you a high-level snapshot.
Okay, I appreciate that, and I certainly understand that this is not scientific survey by any stretch of the imagination, but hopefully it gave folks an outlet for them to express their opinions.
Absolutely.
Are there other questions for Chris? Communication? If something comes up, Chris, you'll be standing by, right?
I will be.
Okay, great. Commissioner Holland, you have another question?
Thank you, Madam Chair. Chris, I'm just wondering, the 12,000 single IP address, do you have any idea where that came from?
We've got the IP address, but that's as much investigative work as we did. We tried to filter out, as I said, we had one that gave 6,800 responses and another one with about 2,300. So that's why in the reports that you have one that includes all of that data, and then one where we stripped out all those duplications.
Okay, thank you very much.
Mm-hmm. Commissioner Jackson, you are muted.
Jolene, can you chat?
Issue are saying we have the data that says, and then they'll say something that's diametrically opposed. If you could help us understand that point, as well as give us the up-to-date information and statistics. Anything else you would like to add, I'd really appreciate it. And before I totally give this Mike, over to you. I just want to thank you for the town hall that you presented, you and your team presented last week. I think our residents find those to be really, really helpful. So we had almost 5,000 people on that call at one point, and that was really, really excellent. So.
It's the PowerPoint. For those listening online, we are running into a technical difficulty, but we are going to get back online as soon as possible.
So Michelle, I hope you and I kind of get our act together and get coordinated. Commissioner Jackson, let me start with your first question, which is sort of the crux of this, which is, yes, I've gotten a ton of emails as well. Actually, over the weekend, they've become pretty apparently templated. Same points made over and over again, same verbiage, exactly same paragraph structure, etc. So, but people are taking the time for sure, but it's you know, like many campaigns of advocacy, form letters are being used. I will say, let me say this about the data. So let me back up and say one thing. I think lively topic was a great neutral term to describe what's happening. I would have to say in my entire public health career, I've never seen anything, I'm trying to think of the right way to put it besides lively topic, as surprisingly contentious as this issue about masking in children. It seemed very understandable to me last year when we began to have lots of contention about the lockdowns and the restriction of businesses because there were jobs and livelihoods and health insurance policies, et cetera, at stake. What's happening now with masking as a prevention strategy that we used pretty effectively last year, it's being used all over the world, is, you know, just, I think we will all have to say, no matter how we fall on it, really striking and, again, to me, quite surprising. The other thing I want to acknowledge, what I said on the town hall the other night, is that I think part of this is honestly coming out of just an understandable, incredible weariness with dealing with COVID. We are also mightily frustrated, whether you're a parent that's worried to send their kids to school without a mask, or whether you're a parent who feels like it's an infringement of your rights to be required to do that, or whether you're a commissioner, whether you're a business owner, or whether you're a public health official. It's just really tiring. And I just think that's part of the reality of what we're dealing with. So enough of a prelude. Let me say a couple of things about your question about the data. First of all, the data on mask wearing are imperfect. There is no definitive data. Certainly nothing as good as what we see with vaccine trials. The best standard, the gold standard of care in scientific evidence from a clinical perspective, clinical meaning it deals with people, are randomized, double-blind, placebo-controlled trials. And that's exactly what we have with the vaccine trials. And that's why that data is so powerful and I think so reliable. It is impossible to replicate that sort of precision with masking. Masking is largely based on observational and epidemiologic studies, and that inevitably results in a lower standard of evidence. But when you have observational and epidemiologic studies from a variety of different settings, giving you a very similar message over and over, and when you supplement that with laboratory-based studies that give you biologic plausibility for why masks of all kinds, cloth masks, surgical masks, N95 masks, will have variable levels of positive protection in terms of preventing me from spreading it to you, that's called source control, or preventing you, if you're wearing a mask, from getting it to me, that's called wearer protection. When you add all that information together, which is what the CDC has done, the compelling message is that even in the absence of definitive gold standard data, the evidence that masks, including in children, because there are data in schools, protect, is really enormous. I will say that there are studies that are being frequently cited as evidence that masks don't work. There was a study out of Germany about kids retaining carbon dioxide when they wore masks. That ended up being retracted this about 3 weeks after it was published in early July because of methodologic concerns. There was a study the CDC published about mask wearing in schools in Georgia where mask wearing by teachers were statistically significantly likely to reduce transmission. They were not statistically significant in children because the confidence intervals, that's a statistical term meaning how broad of a range of possibilities, was just less than being significant. But it was very, very strikingly in the same direction and very, very highly consistent with what's seen in other studies. So I'll be the first to say, as somebody who used to do double-blind, randomized, placebo-controlled trials, that when I can do those, I'd much prefer it. But in the world of public health, if you're not dealing with a biologic tool like a vaccine or a drug, these are often very hard to do. And the best we often have are these sort of observational and epidemiologic studies. So with that prelude, Michelle, I don't know if you've got my slides up, but if we could go to the slide number 2, which is Delta variant overview. And I know the commissioners are well aware of it, but I just think we ought to just set the table. So if you can see this slide, I think you know this is a variant that began in India. We started calling it the Indian variant, or we called it by its biologic name, B.167.2, but we now have an easier Roman alphabet nomenclature. So D was the fourth one identified, Delta. There are several subvariants of Delta. The graph that I hope you can see shows AY1, AY2, and AY3. These are variations in the theme. At least right now, biologically, they appear to act like Delta. So what's the big deal about Delta? Twice as contagious as the strain we saw last winter, twice as severe in terms of chances of hospitalization. 5 different studies, including one published yesterday in the UK with 40,000 observations, show that Delta is more severe in terms of likelihood of hospitalizations. Delta is now about 98% or so of all strains in Colorado, if you include the AY123 subvariants. We were the second highest in the U.S. I think we're now probably, it's pretty much all over the country fairly evenly. And we are probably going to see more of these subvariants. It was one called Delta Plus. That's still being sorted out. I'm not going to talk about that today. I do want to emphasize really strongly that vaccines work. You need to get both doses. When you do, it's about 85% protective in preventing severe disease. But if you get a breakthrough infection, and you can get a breakthrough infection, it looks like you are as contagious to other people as an unvaccinated person. So you buy personal protection, and you do reduce your chances of getting infected. But if you get infected, you can transmit to other people, which is where the mask part of the story comes in. Because you may not know you're one of those people with a breakthrough infection, but you could be contagious. Next slide, please. And if you guys are seeing what I'm saying, this one says Tri-County area pediatric case rates by age group. This was updated by our team this morning. Blue and 0 to 5 in blue, and yellow 6 to 11, and red 12 to 17, compared to turquoise, everybody over the age of 18. A couple of points to be made out of this. First of all, we've gone up dramatically since late June, early July. That's the time period when Delta has really gone nuts. Number two, the age group with the highest rates right now, again, these are across our 3 counties, are those 6 to 11 years old. And across the 3 counties, when we look at rates going back to the beginning of January, when we really were experiencing the worst of the epidemic, the 6 to 11-year-old age group has now got higher rates than they've had at any point during that time. I think the same would likely be true for the 12 to 17-year-old group in red. I think what's preventing them from keeping up with the yellow is the vaccine. So about 50-some-odd% of the kids in Arapahoe County have been completely vaccinated, and I think you're seeing that play out there. Why is the blue 0 to 5 so much lower? I think it's largely because many of those kids aren't in indoor settings with other kids, i.e. schools or child care centers. We are seeing child care center outbreaks, but I think that's what's going on. It's still going up. The slope is almost as high as the older age groups, but not quite. Next slide, please, Michelle.
Dr. Douglas, Commissioner Sharp has a question.
Oh, yeah, please interrupt me, yeah.
Thank you. Sorry to interrupt, just didn't want to get past that slide. So, and it's hard for me to tell, but when we're talking about numbers here, this is the Tri-County Health area, so that's all 3 counties. Can you tell me, like, how many kids are in these age groups that, and we'll just use the most recent data if possible. It's just hard for me to read over. Is it 20 kids on the 0 to 5?
Yeah, sorry, Commissioner. I should have said that. I'm trying to talk too fast. These are case rates. So the average rate, let's look at that yellow thing, which is just over 40. So that rate on the y-axis is a 7-day moving average. So that's a number of daily cases per 100,000 over the past 7 days. Now, I think in part what you're asking is, gee, how many kids does that add up to? And I don't actually have that broken out, although I could get it for you guys. In general, the kids under the age of 12 are about 16 to 18% of the population, but I don't know how the 6 to 11 or the 0 to 5 break out. But that is a case rate, and I'm sorry I wasn't more clear about that.
Okay, thank you. Yeah, just trying to get a feel for how many kids really out of the total population of kids in each one of these categories has been included in these numbers. And the other part of that, and you may be getting to it, Dr. Douglas, is the severity among these cases.
I'm actually not going to get severity, but since you've asked me, I'll comment on it.
Okay.
And the good news is that the severity has remained quite low. While Delta is 2 times more serious, we believe, than the strain that we experienced last winter. 2 times a low number, that is, low numbers of kids who get serious outcomes, is still a low number, even though if you get more and more kids infected, that low number multiplied times 2 gets bigger and bigger. Now that's partly what's going on in different pediatric ICUs around the country. We've been hearing these scare stories from Arkansas, Missouri, Louisiana, Florida, Alabama, Mississippi, where they're running out of ICU beds. We're not there yet at all, but all of my pediatric colleagues are concerned about that because while, again, kids generally do much better with COVID than do adults, there are some kids who get sick. There are some kids who get hospitalized and rarely die. And if the infection spreads, those absolute numbers will spread as well. The other thing I think is worth pointing out, I think you and I may have talked about this last week, is that one of the things that has lots of folks concerned, and it remains frustratingly unquantified, is something called long COVID. Long COVID is a thing where you get persistent symptoms lasting 6 weeks or more. It can include shortness of breath, brain fog, heart palpitations, et cetera, et cetera. Children clearly get long COVID, but we don't know how frequently and we don't know how long it lasts. That's really different than what we see with the flu. Lots of folks make comparisons to the flu. We just can't quantitate that very effectively.
And if I could, Nick Fogg is going to talk a little bit more about severity, Commissioner Sharp, just so you.
Great, thank you. And just since we're focusing on children here, that's really the focus of of this and trying to get information here. Do you have any information on where the Delta variant is, well, for adults and or children? Because it spreads so, what I've read anyway, it spreads so quickly. And I think when the UK was going through it, it went through the population very quickly and then it flattened out. Do you have any data on where that might be in this country and maybe specifically with children?
Sure. Well, let me say that we don't measure every sample that tests positive for genomic sequencing, which is what you need to do to establish whether it's Delta or not. We test a representative sample and then make statistical imputations, which I think have been pretty valid, but it is worth being transparent that these are imputations from about 9 to 10% of all samples tested. That's where we think Delta is about 98% plus. We think that's true in all age groups. Now, what I would say in terms of the question about is it going to go down and when is it going to go down, is we don't know yet. I think you're correct to point out that it went up in the UK and then it came down and it flattened. But when you look at the UK curves, it did not get back to where it was in May, which is in contrast to what happened in India, where it went up like a rocket ship and then it came back down. And it looks like that was an example with obviously much morbidity and mortality, where things probably spread so fast that there was at least a modicum of natural immunity. I don't think that's really likely to be happening in the UK. They're still experiencing plenty of it. But you could look at the curve that I think we're all still looking at and ask yourself, that gold line is starting to come down. Could that represent a reversal? It could, although the reason that last part of that graph is in gray is that recent data almost always lag, and we don't want to bank on it too much because it can be varied. We did see Delta come back down in Mesa County. There was a big outbreak in Mesa County. It's really hard to know whether that was some natural immunity that may have crept in, or whether or not something else changed, more vaccination. I don't think that was really it. Maybe less testing, sometimes that happens. Although Mesa has begun to go back up again. So I think it's a little hard to say where we stand and what could be going on. But right now it at least looks like from an age perspective, kids are every bit as involved or even more so. I hope that gets at what you were asking.
Thank you. I'm sure I'll have a lot more questions, but I don't want to please continue on and I'll hold those. Thank you.
Okay, Michelle, if you could do the next slide, which is one that should just show some Arapahoe County data. And the observation here is that while that gold line isn't quite as high, actually Douglas County is having the worst experience right now of our 3 counties. They probably had the least mask wearing getting going, but you're still seeing roughly the same pattern, which is rates going up 6 to 10, 6 to 11 most, 12 to 17 now beginning to catch up. And actually you see that gap between 0 and 5 beginning to close as well. Next slide, please, Michelle. So if we're looking at the same thing, you're going to be seeing trends in school outbreaks. Now, school only started in many of our districts quite recently, and so let me point out that this is very much a measurement in progress. And what I mean by that is it takes, up to probably 7 to 10 days once I acquire Delta, or COVID, but Delta, to turn up with a positive test. It's got to incubate, I've got to get sick, I've got to go in and get tested, the test has got to read positive, turn around maybe in 24 to 48 hours. So what we're seeing in terms of what we're measuring is probably at least 7 to 10 days behind. Number 2, to count as an outbreak, you've either got to have 5 confirmed cases, or you've got to have 5 cases that are either confirmed or highly suspicious, meaning it very much looks like COVID, and you were around somebody else with COVID, although your test is not back yet. So this is what's happened across our 3 counties since the beginning of August. These are not cumulative, these are weekly numbers. So you can see this past week was obviously the number with the most. The blue is the total number of outbreaks. We had about, I think, 23 outbreaks that week compared to 13 the previous week and about 3 the prior week. Next slide, please. So if I'm still tracking with Michelle, this allows you to see what's happening in Arapahoe County. So in Arapahoe County, 3 high school, middle school, 5 elementary ESC. We have some K through 12 and K through 8 schools, and those have had a total of 4. So a total of 12 outbreaks in Arapahoe County with 52 cases. Now, on the one hand, that's not a lot. But on the other hand, it's the previous slide shows you, and Arapahoe County's trend data looks the same. It's going up quite rapidly. So we think we may be recently damping some of that because our mask mandate went into effect last Monday. In a number of districts, Aurora, Cherry Creek, Englewood, Sheridan, have actually either done their own or followed our recommendations. So I am very much hoping we'll see a damping of this, which is frankly one reason that we would like to keep mask mandates in effect. Next slide, please. Again, I'm having to guess that you can see what I'm seeing. Case rates by neighborhood, it's a map. If that's
Michelle is doing a great job.
All right, Michelle, you and I are telepathically working together. So what you're seeing here, let me walk you through you know the maps. You can see where Arapahoe County sits. But these are 2-week cumulative case rates. And red is greater than 200, and forget the up to 3,000. The data people had to pick an upper limit. Nobody's that high. Orange is between 100 and 200. Pale orange is between 20 and 100, and yellow is between 0 and 20. Now, what those numbers were picked as are numbers to correspond with how CDC measures areas of what they call substantial transmission, which is 50 to 100 cases measured over 1 week. So these are 2 weeks, and that's why that 50 to 100 turns into 100 to 200. Or high transmission is deemed to be greater than 100 over a week, and that's why we use 200 for 2 weeks. So I think what you can see message-wise is that Arapahoe County is pretty much, I think, with the exception, maybe no exceptions at all, pretty much all greater than 200 per 2 week, or greater than the CDC's threshold for high rates of transmission. This is very even across the county, and what I want to point out on the right side, which lists all of the census tracts in our 3-county area. There's over 300 census tracts. These are the top 13 or 14, I think. The rural parts of both Adams, Northeast Adams, and Arapahoe, East Arapahoe, those are the big census tracts that cover what looks like the majority of the square mileage of the county, are in the top 12. East Arapahoe, for example, with a 2-week rate of 526, is the 12th highest in our areas. And so while there are relatively few cases occurring in those rural areas, proportionately they are actually having as high or an even higher set of transmission conditions as other parts of the county. Next slide, please, Michelle. And so this, I'm hoping, is showing you vaccine coverage. I've already referred to this. But this is looking 2 weeks ago, actually it's close to 3 weeks now. Arapahoe's in the middle, 12 to 15 and 16 to 17 are what I put in the red ellipse. 2 columns, percent of people in those age groups who've started a vaccine, more importantly the percent who've completed it. So let's look at 12 to 15 in Arapahoe County in the middle. On August 11th it was 46%. On August 26th it was close to 51%. So that's a good increase, 5% over 15 days, although you can see the glass is still, just over half full in that age group. In the 16 to 17-year-old age group, and again, I circled these because these are school-age kids that are eligible for vaccination, we went from 58.5 up to 60.9. Again, not quite as much of an increase. It's good to see it going up. They're actually going up higher than older age groups, but we still have many unvaccinated kids in the 12 to 15 and 16 to 17-year-old age group. Next slide, please, Michelle.
I'm sorry, Dr. Douglas, I apologize, but I'm not on that slide, but on the one before, was that was just that one, thank you. That's anyone, case rates, regardless of age. So these are not just children, this is everyone included. Is that, I just want to be clear that I'm clear on what we're looking at.
Yeah, you're absolutely right. You're following it correctly. This is an everybody thing. We don't have the ability to show rates by ages for census tracts. We're working on that now, but this is everybody.
Okay, thank you.
Are we good? So, Michelle, I'm on slide, or I want to talk about slide 9, the one that says rationale for mask mandate. So if we're all on the same page, again, I think you guys know this, but I want to pull it together because we're obviously still getting asked, why are you guys doing this? This is crazy. You're interfering with individual liberty, etc. Mask wearing is, let me be very clear, not the be-all and end-all. It's one aspect of a comprehensive set of mitigation strategies. Vaccines, if you're eligible, social distancing as much as possible. That's tougher when everybody's back in in-person learning. Testing when you're symptomatic. Good ventilation, I can't emphasize that enough, that's huge. If our kids could do school outdoors all year, we probably wouldn't need masks. That's not really feasible. Staying home when you're sick or you have a positive test. The use of quarantines. Quarantines mean you've been exposed, you're not sick, but you need to stay away from other people in case you get sick. That was the thing that really upset the apple cart more than anything else in terms of in-person learning last year. We had tons of kids in and out because of class quarantines, and we've been bending over backwards to try to avoid that because it was so impactful in in-person learning. And then finally, close cooperation with public health, which basically means conditions change, and the more we can partner and work together, the better. And I would say really, we've had great cooperation from the districts, especially the ones that I mentioned. They've been very eager to work with us and follow what they think is a reasonable public health guidance. Now, why masks? So again, not perfect, but about 50 to 70% effective in reducing transmission of infection from a variety of observational and epidemiologic studies. Benefits are both source control, me spreading it to you, wearer protection, you getting it from me. Like vaccination, really important to emphasize this, it is more effective with higher levels of use in a given setting. In a class where one kid's wearing a mask, you're going to get a lot less benefit out of masking than if 29 out of 30 are wearing a mask. Very similar to the herd immunity concept, albeit not through the immune system, obviously. And then finally, what we observed early in the game in a number of different districts was that compliance with mask wearing was variable and often really low when it was non-mandatory. And we are, trying to think of the right ways of analogizing this. But if you have a dress code and nobody says, that's not proper clothing, please change it. Or if you have speed limits and nobody puts up signage and nobody enforces it, you're probably going to have less compliance with that. The benefits of protecting infection in children is, number one, individual health, particularly those unvaccinated or those who are vaccinated but who have underlying illness. Kids do not get as sick as adults. That's the question that Commissioner Sharp asked early, but they can get sick, especially those, and we estimate that to be around 5 to 10% who have one or more of the comorbidities that makes COVID more serious. Number two is health of others. And by health of others, I'm talking about family health, particularly in the unvaccinated 6-year-old who's got a parent who's a cancer survivor, or who's got a grandparent living with them and they got their vaccine 7 months ago and we're now beginning to feel that we're going to need boosters, but they're not available yet. As well as community health, because we know the more that Delta spreads in whatever age group, the more the gasoline on the fire has the potential for enhancing its more rapid growth. And then really, honestly, probably most practically important for the kids is the maintenance of in-person learning, the avoidance of disruption due to outbreaks, isolation, and quarantine, which we know had a terrible impact on education last year. and my pediatric colleagues tell me is probably the most important impact on social, emotional development and mental health. Kids are impacted social, emotionally, and mental health-wise by fear that their parents are going to get sick, fear that they're going to get sick, fear they're going to lose a grandparent, fear they can't see their grandparents. But what impacts them more than anything is isolation, being away from their peers, and this is particularly true in adolescents. Next slide, please. So I believe you guys may have mixed in with your 10 million emails, gotten a message from the American Academy of Pediatrics. I got copied on one we received today. And I just want to mention that I have paid a lot of attention to what my pediatric colleagues tell me. So I'm a doctor. I used to be a professor at the School of Medicine and Infectious Diseases. I think I'm a smart guy. But who I really think are smart about our kids are our pediatricians. Those are the folks that have, I think, the most science-based comprehensive views about how to keep our children, the whole child, not the COVID prevention part of the child, not the keeping the kid from getting obese part of the child, but the whole child, the child that needs education, the child that has mental health issues. They put out, the Colorado chapter of AAP put out a statement in early August, very similar to what a national chapter put out, calling for universal masking for all Colorado schools and child care settings. And as the letter on the right side mentions, this went to the governor and the head of the state health department, who, by the way, I still wish would act statewide, but they haven't. And so they also sent it to the Colorado Association of Public Health Officials, me, and my peers in other places, saying, somebody's got to step up. The can is just getting kicked around. It's the governor's job. No, it's the local's job. No, it's the school district's job. And frankly, by about August 11th, 12th, 13th, 14th, it was really apparent that we were just diddling. We were waiting for somebody else to act, and that's honestly, frankly, to my way of thinking, with the encouragement of our pediatrics colleagues, we felt it was appropriate to act. Next slide, please. I want to mention that Children's Hospital is not full yet, but it is getting fuller. And when they speak up and say the same thing, I mean, these are the people that are taking care of our hospital, the kids who are going to get sick to go to the hospital. I listen really closely. This was a statement that they put out 10 days ago on August 20th. And then finally, Michelle, the next slide, you're not going to be able to read this, but this is a clip from the Parents Guide, Children's Hospital again, Parents Guide to Face Masks that came out 2 weeks ago. I want to particularly point out the information they provide about mental health problems. I'd say probably half the emails I'm getting from those who don't support mask wearing say that it's why my kid is anxious and depressed and maybe even has suicidal ideation. That is absolutely the opposite of what the behavioral health specialist from Children's Hospital, who, by the way, did declare 3 months ago that they thought we had a mental health emergency in our kids. What they're saying is there's no scientific evidence to support that masks cause mental health issues. In fact, they point out that it's other factors, disruptions to routine, isolation, stress, and anxiety due to the pandemic. Again, I'm not going to read this whole thing, but and you may not have time to read it as well, but when I've got, I think, the most expert people in the health of children speaking out, that's when I listen the most closely. I think I've got one more slide, Michelle. Maybe two more. This is a comparison that CDPHE's been doing with a handful of other states. This one is Indiana, looking at the question of what happens in cases by school district, whether they have mask policies, that means masks are mandated, versus those that do not. Orange is those that do not, blue is those that do. They're tracking this week by week. As of last Wednesday, I think Dr. Hurley, you shared this with us, the preliminary estimate was a reduction of about 38% in those districts with mandates, not just please do it, but a mandate, versus those that didn't. And then finally, Michelle, we'll move to the last one. Commissioner Sharp, this one's dedicated to you because you asked me to talk a little bit about what to expect. And I do want to say, I thought about this weekend. The pandemic has presented all of us with an unprecedented, vast amount of science and opinion to digest. You've gotten this in spades over the last week. And that while I, like you, am interested in public opinion, I feel like that my responsibility is to make decisions based on the best science available. And because there is just such a floodgate of science, better science, not so good science, I don't know about you, but I have to rely on some entity that's going to curate that science for me. It's like I'm going in the Louvre and there's 10,000 paintings, and what am I going to look at? I've got to have an expert who can sort out the data and tell me what to pay attention to and what not. And that's why I pay attention particularly to CDC and AAP, the American Academy of Pediatrics, but also our own state health department. I will say the variables that we will be following, whether mandates exist or not, are going to be case rates by county and census tract, our county case and hospitalization rates among kids, our hospital capacity numbers, I think Nate's going to talk about that, our school case and outbreak numbers and trends, and our vaccination rates. And then I think on everybody's mind, including mine by the way, is how long does a mask mandate need to last? And I would say no longer than needed, but that is an ambiguous answer, and it's really going to be determined by the data, what are we seeing, experience here and other locales, and expert advice. And I'll note the obvious that it's going to be dramatically benefited by FDA approval and subsequent high rates of pediatric vaccination. So Michelle, thank you for being my partner. I'm happy to take other questions. Again, I'm sorry to chew up excess time for the meeting today.
Trying to unmute. Okay, thank you so much, Dr. Douglas, for that really comprehensive and informative presentation. We'll take a few questions and then we'll hear from Nate, and then we'll have some discussion. So Commissioner Baker, then Commissioner Sharp.
Thank you, Madam Chair. And thank you, Dr. Douglas. I want to say, I know that this has been a very difficult time for you and your staff, and I know how much hard work went into preparing this information for us. And I think I know the answer to the first question, but I just want to make sure. You didn't present any data about deaths of school-age children that I saw. You did say that the severity is pretty low for school-age children. Is that correct?
Yeah, I did, Commissioner, and I did not present death data. It's a very small subset of the hospitalization data, which has been in and of itself quite low. So I want to be very clear. Severe outcomes as measured by hospitalization deaths have been quite uncommon in children. They happen. They'll probably increase as Delta increases, but they've been quite low.
Thank you, Dr. Douglas. The next question that I have is, I'm just wondering what your opinion is about the 2/3 of your constituency, Adams and Douglas County, voting to opt out, and wanted to get kind of, how do you feel about that?
Well, I'm not wild about it. I'm disappointed, frankly. This has been a very contentious issue. As I think you all may know, our board has got a meeting at 4 o'clock. I'm going to give them an update similar to what I'm giving you. We're going to talk honestly, Commissioner, about the policy the board adopted last year, allowing county opt-outs. I think it's frankly been somewhat problematic. I've asked our team to look at how effectively we really are able to carry out our statutory duties, and the answer is probably not optimally. So I am disappointed. I'm very happy, by the way. I'm always looking on the bright side, that so many of our school districts have looked at the order and said, you know what, even though our county opted out, we think it's really important and we're going to do it. Now, I will tell you that most of the superintendents tell me our hand would be strengthened and we could do this more effectively if there was an order in place. But if you say it's an order, even if our county opts out, we'll do the best we can. So, wrapping it all up, Jeff, disappointed, although I really do understand why elected officials, if I pass the hot potato to them, have made the decision that they have made.
Thank you, Dr. Douglas.
Commissioner Sharp, and then if you don't ask my question, I'll go next.
Okay, thank you, Madam Chair. Well, maybe just a couple of things first that, and I think probably everybody on this call would know my position, that I would have hoped the decision would have gone to the school board as elected officials to make this decision, but that's not here nor there at this point. But one of the things that I do think going forward is going to be, and I have a couple questions, but I do think that going forward, it'll be important to try to, and I don't know how you do this, probably more difficult than I'm thinking, but by school district to try to get data. And so that if we have 50,000 kids in Cherry Creek School District, how many outbreaks do they have? If they're requiring masks, how many, because we all know that this is not going to prevent kids from getting COVID or going home. I mean, we just had, and the disruption in the class, while I think that's, I really hate to see that. I absolutely want kids in school, that even mask wearing is not going to prevent disruption. We've already seen that in the data that you demonstrated to us. So I think it will be important to try to get that not only by census tract, but maybe the school districts could have some way of providing that data to you as Tri-County. I think the other thing that I think is important is strengthening the relationship between the school boards and Tri-County in terms of data and information, and making sure we've gotten over the last, as elected officials, over the last year and a half, up until recently, meeting, every Tuesday afternoon to be able to hear what the latest was, ask our questions. And I think that's been extremely helpful in us and kind of keeping track of where things are. And I'd sure like to see that level of interaction with our 9 school districts. I think I'm right that it's 9, to improve all of our understanding, parents as well as staff and school board members. So just those kinds of things. So 2 real questions would be in terms of the hospital data for kids that I think you were talking about, children's. Are those COVID, or are they all the numbers and that are increasing at children's? Is that COVID, or I know a lot of the emails we got were other respiratory issues that kids are in the hospital for? So I just wanted to make sure I'm clear on what that reporting is.
Yeah, good question. Right now, the number of pediatric hospitalizations has not yet started to go up. They're really low. Well, I'd say they've gone up only very slightly. There is a slight increase, but not a very big one. What they have been seeing is more of something called RSV, respiratory syncytial virus, highly transmissible. We had an incredibly mild year from that last year, frankly, probably because of mask wearing. And it's popping up now, I don't know, 2 months earlier than it did last year. So there are far more kids in the hospital right now with RSV than there is COVID. I will say that, a hospital bed is a hospital bed is a hospital bed. It doesn't matter whether you're there with a heart attack or appendicitis or RSV or COVID. We've only got so many. And so if we have a flood of RSV, then, COVID prevention in some ways, from having enough beds to take care of people, is probably even more important. But at least right now, we're not like New Orleans or Jackson, Mississippi. Most of the increased demand that the my colleagues in pediatrics tell me is due to other respiratory viruses, particularly RSV.
I apologize. Go ahead, Dr. Douglas.
Well, no, I just want to say I really appreciate your suggestion about the school boards. Really more susceptible population that could result in a higher year. It's going to be, I think really, in all honesty, it's only time will tell.
Okay. Yeah, I will end with, I don't know if I'll have another question. I can't, no promises there, but, you know, but I just think that the more data and the more perspective, you know, in terms of the number of kids in our school districts, and showing that with, like you've done with other data for adults, could be really helpful in helping to answer questions and shape future decision making. So, thank you.
Yeah, I do want to say our data team has been working on a dashboard that's supposed to go live today to put up a lot of what you've talked about, which will include numbers of outbreaks by school district. So we are really very much appreciate the kind of feedback you and others give us about this. Would really help me to see that. So at least that particular information ought to be available. I hope I use it today.
Thank you. And I think, you know, putting things in perspective, of course, none of us as parents, and now me as a grandparent, wants any of our children, everybody who's weighed in on all of any issue, or no matter what side, you know, everybody cares about their children and their grandchildren and want to do the best for them. We've got a pretty big difference of opinion here, but that, I think it's, everybody knows that people want to do the best for their kids. And I think just making sure we put, you know, if it's 75 kids out of 75,000 or 7,500 or, you know, something like that, makes a difference. And that's what we've really tried to, with your help, zero in on a lot of that with our other data. And so I appreciate taking, and we'll work through that. And that's why I think involving the school boards and superintendents, I think would help to get the information they feel most valuable in helping them to make good decisions online. So thank you.
Thank you. Good questions, and I think we all agree that everybody cares about their kids and their grandkids. I think bottom line, that's true. We just have some differences in whatever, how we interpret the information or the information that we get. My question is, however, Dr. Douglas, you may have just begun to speak to this issue, and I don't want to say anything that you're not comfortable with, but we've been getting a lot of emails today about a meeting of the, well, it was a little confusing. Some thought it was the Tri-County Health Board, some thought it was this meeting, but nevertheless, that there is going to be a meeting this afternoon of the Tri-County Health Board. Can you tell us what's going to be on the agenda?
Sure, Commissioner. three topics. I'm going to give our board an update on where things stand in terms of COVID, epidemiology, school outbreaks, both in general, but particularly among our kids. So a little bit of an expanded version of what I gave you guys this afternoon. Number two, we're going to have a discussion about the opt-out policy that the board created last November to sort of assess how it's been working and to determine whether this is a policy that we ought to continue going forward. And then the final thing is realizing you all are on the cusp of deciding what you as a county want to do about the existing mandate. But we do, as Commissioner Baker asked me, or pointed out, we already have two other counties that have opted out of it. What ought we to do now in terms of a mask mandate? And so what are reasonable next steps going forward? So those three topics, update, opt-out, and mask policy going forward.
Thank you, Doctor. It is, as we say, time is of the essence in terms of this board and how we go forward. But I do appreciate your careful and thoughtful explanations and do that. So next we'll go to Commissioner Warren Gully, and then we'll hear from Nate Fogg, our Emergency Operations Manager.
Thank you, Madam Chair. Thank you so much, Dr. Douglas, for your time and the information that you're giving us today. It did give me some really great insight into some of the questions and comments that we've gotten from our community. One question that I had for you is that currently the mask mandate is for children ages 2 through 11. My understanding is that there's the potential change that it would be older than 2 to 11. Am I hearing that correctly? And is that a possibility that might change, that it would be over 2 and to 11?
So we have been having internal discussions, Commissioner, about what is the right lower age. You may be aware Jefferson County made the decision to up the lower age to 3 rather than 2, based on the feedback that it's folks in child care centers have made about it being tough for kids to consistently wear masks. I will say that the frequently asked questions that we have provided along with our current mandate makes it quite clear that what we're looking for in child care centers, 2-year-olds, 3-year-olds, even 4-year-olds, is the centers doing the best they can. We understand that I just spent the week, and at least part of it, with my 2-year-old granddaughter, and I get it that it's tough to get them to wear masks. Even the 3-year-old, we have to keep reminding her and this kind of thing. So we are trying to make it quite clear that what we're looking for is and we've given the child care centers some ideas about how to do this, but the last thing we're saying is send them home. We're not looking to say if a kid can't wear a mask 100%, they're out. The parent has to find some other provisions. I will say I've been in touch with the several colleagues in the AAP, American Academy of Pediatrics this morning to sort of get their best understanding, because their language on their website was a little unclear.
Yes.
It said over 2, and the CDC says 2 and up. And what I've had explained to me this morning is over 2 means over your 2nd birthday.
Okay.
Meaning when you hit day 730 of life, your 2nd birthday, if it's not a leap year, then you are 2, and over 2, they do recommend masking consistent with the CDC. And the reason they do that is they feel that, kids aren't going to understand at that age, why do I wear a mask? Let's be very honest about that. But they do have the manual dexterity to put their mask on once taught how to do it. And frankly, like I had to do with my granddaughter, once reminded over and over again about doing it. So they are, like the CDC, sticking with 2+. This will be discussed this evening. I am guessing that any future guidance or even mandates that we put out probably would stick with the AAP CDC guidance, with the caveats to the folks dealing with young children, that we're expecting efforts, but we aren't expecting and certainly aren't interested in penalizing people for lack. And some are not, or some are mandating, some are not. You have a kind of, if you will, a natural real world experience. And we'll be looking at that pretty closely. But you are right on the nose. The ability to measure that which doesn't happen, whether it's, you know, how many people who evacuated from New Orleans would have died if they hadn't, we're never going to know. Just is really a challenge. So we'll try to do the best we can using those sort of comparative studies, but it is a dilemma.
Okay, thank you very much.
Okay, hopefully we can come to some conclusions by 2:30, but we'll just keep going. Commissioner Holan?
Commissioner Holden,
You're muted. There we
He's
go.
back.
I think Commissioner Gully's point is very well taken. It's hard to perceive success when it comes to defining and measuring with a matrix prevention. However, one of the issues that I think we need to look at, and I think maybe Dr. Douglas can address this, is we saw in the early stages of this pandemic certain areas of the country that begin to accelerate a lot faster than Colorado. And I think we're seeing that obviously now in terms of those states that didn't really didn't come to the fold and start some very effective preventative measures in this, such as the South, Texas and Florida and Mississippi and others. Can you analyze, just kind of off the top of your head, the infection rates and death rates that are occurring in those states with children in this very vulnerable population area that we're defining by the Tri-County Health Department? In other words, can we potentially see, if we don't do anything, an increase in the severity and the numbers of infections if we don't act?
So, Commissioner, that's really, that latter way you put it together is an excellent summary of why we've been wading into these controversial waters and pushing requirements for masking, is that we do believe, particularly in those that are not vaccinated, that the potential for the sort of things that are being seen in the southern states that are in the news these days could very easily happen here. Are we different enough because we've got higher baseline vaccination rates, or because we have a less humid climate, or because we're less in the air-conditioned interior? Maybe. But what's the right way to sort of make that question or make that determination? I think we could very easily see what's happening here, even though I can't predict it with certainty what's been happening in those states. The other thing I wanted to quickly point out is that, you know, when some analyses were done, I think it was, gosh, maybe 5-6 months ago, they looked at how Colorado did in the epidemic. Colorado had some of the more strict measures in terms of social distancing, which is a euphemism for businesses having less capacity or even being closed. And one of the observations was that Colorado had probably more economic impact. And I know this board, like others, pointed out to me what a terrible Sophie's choice that represented. It is worth noting that Colorado had one of the lowest death rates in the country, but we had a lot of sacrifice that we made in terms of economic impact. And I think it was a very legitimate debate as to, what's the right level. For this is so different. This is so different because the trade-off is not businesses closing or people losing health insurance. The trade-off here is the kids doing in schools back together what they did in the springtime when they were together. So I think the fact that we have had historically a low death rate by doing the things we did, there were some trade-offs, but I think this is a place where the trade-offs from at least pretty explicit outcomes that I can measure seem to be very much weighted toward the masking. I hope that gets at what you were asking. It was a little bit of an editorial, maybe.
Okay, thank you. Let's move on to our emergency operations manager, Nate Fogg. Nate, you've been with us throughout this, and we really appreciate all the work that you've done backstage and in conversations with us and with others. So, Nate, do you have some information to share with us today?
Sure. Just off the top, right now there are currently 11 kids, COVID patients hospitalized at Children's with 13 PUIs. Remember, that's patients under investigation. So potentially a doubling in cases if those get confirmed there, or doubling in hospitalizations, I should say, at Children's. Within the county itself, right now, we see that we have 66 COVID hospitalizations, and that's down over the last couple of days from a peak of 85 this month. So a decent decrease there, but still higher than we've seen overall. We have a pretty decent jump in our wastewater monitoring systems, and you see this bottom graph kind of tricky to, there we go. There's a significant increase in the estimate. Again, that's a mathematical estimate of active cases in the rural water basin, wastewater basin, well above 5,000 people now, with this again being somewhere around a 15-day indicator. So that's kind of the story on hospitalizations. We did do some recent number crunching, partnering, as you know, we did with Mako, who runs our testing sites, and we're able to get data sets from them going back to June. And what you can kind of see on this graph are that the light blue are negative tests, and the dark blue are positive tests over that time frame. The far left point over here is June 30th. The most recent data set we had available was to August 14th. And we were able to break that down with self-reported age, race, gender, and then zip codes. And so what we're seeing in that 2 to 11 range are very minor numbers, as far as, on this date, on August 12th, there were 32 positive test results in that 2 to 11 range. So it looks to be tracking in most instances at or slightly above the average for the population as a whole. So
Nate, are those national figures or Colorado figures?
This is data out of the Mako COVID testing site at the Centennial Hospital. It's Colorado. If I zoom out of that, you can see by data repopulate here by zip code, there are a lot of folks that come from out of state and out of the area. You can see we have a number of folks that have come from California and Wyoming and all parts of Colorado based on their self-reported zip code that are getting tested there at that Mako site. So I can't say with certainty which percentage are Colorado residents, but the majority are. You can see by the highlighted zip codes there within the metro area. So we'll keep working on this data set, but we do see that those positive test rates are a little higher in that 2 to 11 range than said that 12 to 17 grouping, which is the vaccine eligible folks. So we're monitoring it continually, of course, along with all the data from the Tri-County Health Department that Dr. Douglas expertly demonstrated today. So with that, I'll kind of pause with if there's any questions and leave us a little bit of time to wrap up here by 2:30, Commissioner.
Thank you, Nate. I appreciate that. As always, informative and interesting. So if there are questions, that's fine. We have a few minutes for questions, or if someone would like to give direction to staff in terms of tomorrow, we're open for that. So let's try and figure out where we go from here. Commissioner Baker, you have your virtual hand up.
Thank you. Yes, Madam Chair, and I know Commissioner Sharp wanted to say a few things too, but I just wanted to say, first of all, I give kudos to Tri-County Health Department. I give a lot of compliments to them for taking this on, and I agree that Dr. Douglas said it was controversial and they waded right in. I do think, and I agree 100% with Commissioner Warren Gully when she said that measuring prevention. I also want to say that I think these questions are less binary, yes or no, and they come down to what degree or how much can we reduce illness. And I think we have to act with the assumption of positive intent by Tri-County Health Department and the Board of Health to do what they think is the right thing to do for our school children and for our overall population. I think that's their mandate, and I think they did that. I think that was wise of them. I also think it was wise of them to include an opt-out option. I don't think that they're any less wise because they included the opt-out option. In fact, 2/3 of the counties that make up Tri-County Health Department have made use of that opt-out. I am concerned about any action that the Tri-County Board of Health might make today at 4 o'clock meeting because of the fact that it's already after 2/3 of those counties have chosen to opt out. And I believe that it's kind of singling out Arapahoe County to change the goalposts before we have a chance to make our decision about whether or not to opt out. I think it's more a matter of timing than it is of any intent to single Arapahoe County out. But if in fact they expand or remove the opt-out option at 4 o'clock, I'm concerned about how that would play with our citizens. I do think that there's something to be said for all of the information that Dr. Douglas provided. I do believe that he was talking numbers. He always does talk numbers, and the majority of folks go to school in the urban area. We do have a smaller population that attend schools in the more rural part of Arapahoe County that I represent. I would be remiss if I didn't use that to say that I think we need consistency between Arapahoe and Adams, and maybe even Arapahoe and Douglas, if there are students that travel across county lines to attend school in other jurisdictions. I am an advocate for opting out the entire county or opting out the eastern or rural part of Arapahoe County if opting out the entire county is not an option. Saying that, I will urge people, I know there are high emotions on every side. I'm urging people to, like me, assume positive intent of everyone on this board and the Board of Health and their school district boards. Please be respectful of people's opinions, and I have no tolerance for any threats or violence. Saying that again, I would recommend that we have staff prepare tomorrow's public hearing for a countywide opt-out or a portional opt-out. Thank you, Madam Chair.
Thank you. Should I ask for others to support that? Is there support for Jeff's idea? Can I see thumbs up or some of the county taking a position of opting out or taking a position of partial opt-out? Do I see support for that?
I would support. I think I made that clear that I don't want to override other elected boards. I believe that it is different than the county mask mandate that we discussed in the past, which applied to businesses, and I think that I firmly believe that school boards should be their elected boards by the parents in their districts, and they should be listening to the parents and determining with the data that I've already discussed and input from Tri-County, which I think is really critical, and that ongoing communication, that they should make these decisions for their school districts, and it may be independent from the rural areas, may have different information, but also the urbanized areas. And I think one of the other things that we need to continue to look at are what are vaccination rates, transmission among kids, is the parents that are, or not parents, but adults that are transmitting to kids. And if so, adults need to be more careful. They need to do what they need to do to protect their children. And so, yeah, I know we're not voting. I think the other thing is that Commissioner Jackson would be, whatever outcome the board takes, the Board of Health, sorry, takes this evening could impact what we are able to do tomorrow morning, whether I support opt-out or not. If the Board of Health makes a decision that makes our decision moot, I think we need to make sure, we'll need to adjust and maybe pull our agenda item off of the agenda tomorrow morning if we have no, which is their prerogative to do as the health board. For example, if the Board of Health determines that there is no rescind the old order and there is no opt-out option, then that means that our board has, that choice is not up to us. So I would say, I would recommend that we allow our staff to communicate with us after the Board of Health decision tonight, and then take the appropriate action for agenda items tomorrow. But I also want to, I know there are people who are watching and are all listening on, and I tried to get to, I think we all did, answering emails and thanking people, but we all heard whether you're for or against opting out appreciate this is what local government is all about, that's closest to the people. And I think we need to keep that up, regardless of who any of us agree or disagree with each other. It's important to hear from everyone, and that's how we and Tri-County Health, that's how we can try to make good decisions, the best decisions. So thank you, Madam Chair.
Okay, thank you. So what I heard was if depending on what Tri-County Health does tonight, Jeff, I think we can't really give staff that kind of direction until we find out what Tri-County has to say. But we're a little over time, but let's go ahead. Commissioner Holland has a comment, and then maybe we can talk about giving direction to staff. So, Commissioner Holland.
Thank you, Madam Chair. I think it's clear from all the data that's been brought forward by Tri-County Health that there is a concern, and it's a major concern about the potential of not masking up in passing on this terrible, insidious pandemic virus to not only their fellow students, but also their parents, and vice versa. It's clear that we're seeing increases, as Nate from our suggested in his comments, that there's almost an apparent doubling of infections amongst our younger constituents. So I think that we really have to rely on the science here and not rely on pressure from a variety of groups, some of which are valid, some of which aren't. And I certainly support parents having the right to express their concerns and try to determine what is best for their children. However, we can't do that at the risk of potentially infecting other people and other community members. So I will withhold my decision as to what we should do, and I agree with Commissioner Sharp that we should not make any decisions until we see precisely what the recommendations are from Tri-County Health, and so I support that position.
Thank you. Okay, so thank you all. I would totally agree. Even though we were on a break, some of us were on vacation, we did receive a number of emails and phone calls and so on, and I know I had an out-of-office response, but that doesn't mean that I wasn't looking over and reading a lot of those messages. So this is a very conscientious board. This is a board that cares very much about our communities, and we take this very, very seriously. So thank you, everyone, for your contributions. I think, as has been suggested, and as we kind of thought through, the best recourse for us is to wait until we find out what the Board of Health decides this evening, but to go ahead now and ask our communications director and to have permission to remove the item tomorrow if Tri-County Health makes some other decision. So I'm not sure I worded that correctly, but we can go ahead and leave that for this evening. Mr. Carl, do you have some comments on that, please? Help me word this more correctly.
Yeah, I think what I'm hearing is there's a desire to allow Michelle Halstead to pull the item if Tri-County takes action this afternoon, which essentially renders the issue moot.
Yes.
And she would go ahead then tonight and pull it and repost the agenda, taking that item off of the agenda tonight. To otherwise leave it on, if that doesn't happen, if Tri-County doesn't do something that renders the decision moot, to go ahead and leave it on the agenda for tomorrow morning, and then you can address the issue in the morning. Is that
Okay.
correct?
That, I believe, is what we were trying to say. Is there agreement with that? Any dissent? Seeing no dissent, Ron, I think that sounds like the wisest course of action. Okay, thank you. So, do we have any other issues or comments? I just found the page that I need to be here. So the board has an executive session this afternoon. If we have further questions, Tri-County Health Board of Health is also meeting this afternoon. So if we can listen into that and find out how we go forth tomorrow. So, any other questions or concerns? We are late for our 2:30, but we need that mic.
Thank you to Dr. Douglas and Tri-County Health and Nate Fogg for being here and taking the time to get us up to speed and filled in on their reasoning and the work that's been done so far.
Thank you. And it has been a rocky road, as we all know. So thank you all. Thank you, everybody in our virtual room. Thank you, Tri-County Health, Nate Fogg and others, Michelle, Ron, Carl, all those that have been working on this. So thank you all, and we'll see what happens. So thanks, and I think we need the OCC